Hi guys, Mrs. Hall here. Today I am doing a pre-recording for our class because we are planning on doing assisting with diagnostic procedures as well as administration of blood and blood products. This recording will cover administration of blood and blood products because I want you to be able to get this wealth of information and be able to process it well instead of us having to rush through it tomorrow. I'm just afraid that I will not be able to have enough time to get this done tomorrow. So we will talk about blood transfusions. Now, blood transfusions, they're routine medical procedures in which blood is donated. It can be something that they pay you to do, or it can be voluntary. And they usually put in a narrow tube in a vein in your arm, and they extract the blood into a bag where it is tested and stored. Now, this can be potentially life-saving for someone else who has lost blood due to surgery or injury, or they can also have some kind of illness that prevents the body from making blood or some blood component. Um, Blood transfusion usually happens without any kind of complications. However, we still maintain that you must do very diligent monitoring of your patient as well as take precautions when administering blood in terms of the rights of medication administration. Why do we do blood transfusions? Now, people can be transfused any part or parts of the blood that is donated. Blood that's donated are usually broken down into different components, and some of those are red blood cells, white blood cells, plasma, and platelets. With those components broken down, then that person can get directly what they need. The most commonly transfused is red blood cells. So let's talk hemoglobin levels. Normal values for males and females differ, with males having 14 to 17 milligrams per deciliter and females having 12 to 15 milligrams per deciliter. It's normally thought that this difference is as a result of the monthly blood loss by females as a result of menstruation. However, based on a paper that was written by William Murphy in 2014, it is clear that mean hemoglobin levels are different between males and females, with women having approximately 12% lower hemoglobin levels than males. But this is consistent throughout many species of mammals, birds, and reptiles as well. So with that, we look at it as something that is a direct effect of sex hormones, both estrogen and androgen, on erythropoiesis, which is the development of the mature red blood cells. Since there's no difference in erythropoietin levels, erythropoietin is that hormone that is produced by the kidneys, which has a role in red blood cell production. So there's no difference in the erythropoietin levels, but there's a difference in the development of the mature red blood cells. Now, how does that play a role? Estrogens dilate your kidneys, your vessels in your kidneys, and androgen constrict those renal microvasculatures. So with that dilation and vasoconstriction of the vessels, it then decreases the hematocrit levels in the arterioles, capillaries, and venules. So then it actually alters the oxygen delivery per unit of red cell mass and provides a mechanism for varying red cells as well. So with that, we look at that difference being as a result of our kidney function based on our hormonal levels. So let's look at this red blood cell life cycle. This red blood cell life cycle runs about 90 days. So your red blood cell goes through that erythropoiesis, where there are 4 different stages of erythropoiesis where the red blood cell develop. And then at the end of that cycle, we're going to pick up. This is an extract from a video that I made about hyperbilirubinemia. So I had to explain how the red blood cells are broken down, and that then results in your hyperbilirubinemia when it does not go how it's supposed to. So let's just go ahead and watch about a minute of this.
This
This is a brief description of how jaundice or icterus works. The end stage of that life cycle is started with macrophages breaking down the red blood cells so that the body can get rid of them. This happens mainly in the spleen and the lymph. Hemoglobin is broken down into heme and globin. The globin part is easy for the body to sort out because it gets recycled to the body. The heme part, however, is further broken down into unconjugated bilirubin and iron. Again, the body has use for that iron, so it gets recycled. The unconjugated bilirubin, though, is toxic and cannot remain in the body. So it hitches a ride on albumin to the liver, where the liver adds some glucuronic acid to change it from a fat-soluble to a water-soluble substance so that the body can get rid of it. The water-soluble substance is called conjugated bilirubin. This conjugated bilirubin is stored in the gallbladder as bile, and then we eat and drink, and it slowly is released into the gut, and then again affected, but this time by bacteria. The bacteria work at breaking down the conjugated bilirubin to urobilinogen and then urobilin. The body can then excrete this as feces, where it shows up as the color of stools. Not every system is perfect though, so some of it goes back into the blood. In the blood, this is already water soluble, so the blood can get rid of even more through the kidney, where it shows urine as the yellow color. The rest goes back into the liver and gets to go through the entire process again. All right, so that's just basically what happens when that end of that life cycle actually happens. So your life cycle takes 90 days, just about. So one of the things that you're going to notice in a presentation is you can only donate blood once every 3 months. This is Blood types. ABO is the best known system for grouping blood types. We look at it in terms of your ABO as well as your RH. So your A and your B as well as your RH are the antigens that we pay attention to. So it's based on either the presence or absence of an antigen. So let's talk about antigens and antibodies for a little bit, just so that we can understand where we're coming from. The antigens and antibodies are kind of like the immune system's defense mechanisms. White blood cells produce antibodies, or antibodies are our body's fighters. So the antibodies will target an antigen if they consider it to be an enemy or a foreign object. So if your body has a B antigen, then your body is going to be fine with B. However, if A antigen is introduced, your body is going to throw a fit. And that is what is called a blood type mismatch. All right, so that's what causes your reaction when your body sees that antigen as a mismatch. So let's go into another topic. The universal donor and universal recipient. So when we look at the chart, we see the donor blood types horizontally and the recipient blood types vertically. So if we look in the O negative column, we will note that the O type has no A antigen, no B antigen, but it also has a negative for the rhesus. So that then means that that person would be a universal donor. So those same rules are reversed for that universal recipient. So if we look at the AB positive horizontally, because now we're looking at a recipient, our AB positive has both the A, the B, and it also has the RH. So any of those other blood types can donate to your AB positive patient, making that person a universal recipient. Medical errors. So one of the first things that we're going to pay attention to is the rights of medication administration. You are going to make sure you verify your blood products with a second nurse. Remember, I just spoke to you about at every stage of this blood's activity in the healthcare system that you are going to check the blood and make sure you keep checking it. So right now you are going to be the administrating nurse, but you're not going to be the only person who has checked that the donor blood and the recipient have blood types that are going to match. So check the patient name, the hospital number, blood group, and RH factor, the expiry date on the drug. Make sure that you correctly identify the blood products and match it to the patient, because that reduces medical errors and the adverse effects that the patient may face. So when we're talking about cold chain now, cold chain is basically just making sure that your blood has been kept at a suitable temperature for it to be viable for use. Now, in Belize, policy indicates that blood must be used within 30 minutes of arrival to the unit. So be on point with your transfusions. And that transfusion has to be completed within 4 hours of its commencement. All right? So make sure that you check the blood. Check the blood for any clumps, any kind of separation, making sure that its color is something that is viable. You know, red. Red is a good color. So if you find that there are any abnormalities, you must not transfuse the blood. Return the blood to the blood bank. Make sure that you make a note of this. Your documentation is a legal document, so be sure to document well. So when you are setting up your drip set, you want to be sure that you use the correct drip set, because blood administration actually has its own drip set, which we'll have a picture of in the next few slides. So you want to use that drip set that has a filter on it because you want to prevent the passage of clots. And then when you have already had everything set up, you want to closely monitor your patient. You want to make sure that you take vitals at least every 5 minutes for the first 15 minutes after you're done start the transfusion, and then you're going to do every 15 minutes afterwards. So that is actually policy that is dictated by your Ministry of Health. So make sure that you regulate the flow. Now, this is very important because we don't want that blood to run through too fast. That can cause complications. So your transfusion is supposed to be finished within 4 hours, and you have to make sure that that happens. So calculating drip rates will be very, very important. So most bags come in 500 cc units, so it'll be either 500 cc's or 250 depending on what blood product you are administering, making sure that that goes through in 4 hours with a tubing that has a drop factor of 20. You will be running at 42 drops per minute. So you want to make sure that, like, stuff like on platelets, your platelets won't be 100 cc's. So your platelets have to run through at something like 8 drops per minute. So you have to be cognizant of how to calculate your drip rate, because you don't want to overload your patient and then you don't want it to go beyond that 4 hours so that you end up wasting the blood products. So make sure you do your best to prevent overload and prevent wastage of that very, very scarce commodity. So when you're finished with all this, you are going to be sure to flush with saline and just make sure that you again monitor for overload, because you still want to make sure you restrict this patient with fluids, but you still need to push through that 500. So make sure that you monitor that as well, because now you're going to have the 500 of whole blood and the 500 of saline. You don't want it to go through too fast. This is your blood administration Y set. This Y set happens to have 2 spikes. One spike that is to be set up to the saline, and the next spike that is to set up to the blood. You use what is instructed by your facility. Most times in Belize, we will see these sets having only 1 spike. We often have protocol for institutions to have 2 lines running when you are administering blood. Now, this is very important, because when you have a 2 spike Y tubing like this, your patient throws a reaction. If your patient has a reaction, you still have to put through about 10 cc's, 20 cc's of the same blood that they're reacting to before that saline can reach. So it's important to be able to just close off that blood line and open a saline line if you find your patient has shown an allergic reaction. So what do those reactions look like? So here we have a list of some of the signs and symptoms that you may see from a patient who's reacting to a blood transfusion. Keep in mind that most of these reactions become evident within the first 5 to 15 minutes of initiating the transfusion, but it can develop at any time during the transfusion. So reactions come in many forms. You have your hemolytic reaction, you have your febrile reaction, you have your mild allergic reaction, and your severe allergic reaction, as well as sepsis. So what do you do? I mean, what do you really do if you have a patient that's showing a reaction to the blood that they're receiving? The first course of action: discontinue the transfusion. The transfusion is the problem. If that's the problem, let's cut off the problem. So in case of any reaction, immediately discontinue the transfusion. Make sure that that normal saline line is open. That's why we specify you have two lines, one for the blood, one for the saline. You run through that saline to create that flushing effect. You have to notify the physician, notify your nurse in charge that you have a person that's having a reaction to a blood. You have to administer any kind of treatment that is ordered. Sometimes you will have antihistamines that are administered before your blood transfusion, but you definitely will have something that is ordered if you have a patient that has a reaction. Make sure you stay with that patient, closely monitor them for any kind of complications so that they can have complete resolution of that reaction. Of course, you're going to go forward and notify your blood bank. Make sure that you get your samples, that you can send them off to the lab. Now, with those samples, you are going to make sure that you take the sample from the opposite arm. So if you have your blood on your right arm, you are going to use your left arm to grab the sample and send off to the lab. You also want to gather your first urine that is passed after you've had this event. You want to collect the first urine because you're checking on kidney functions, as well as make sure that you document the transfusion reaction based on whatever institution you're working on, because there may be slight differences based on private or public institutions, or the documentation might be a little bit different. So, in terms of your documentation, nurses' notes, make sure that you document time and date. Make sure you note the type and the type of the blood product, how much you had started with, how much was infused if you had a reaction. So or if your time ran out on you, you passed that 4-hour period. Make sure you note patient blood type and RH factor, as well as that blood that you had given. Note the start time and the end time of the transfusion. Make sure that you note the presence of any allergic reaction, your pre and post vital signs during the protocol, during procedures as per protocol. So if your protocol says every 5 minutes in the first 15 minutes and then every 15 minutes thereafter, that's what you need to do. If your protocol says every 5 minutes for the first half hour, then that is what you need to do. For the Ministry of Health at the moment, the protocol is every 5 minutes for the first 15 minutes and then 15 minutes after. Any pre or post transfusion medication that you're going to administer, please make sure that that's noted. And every single patient that needs blood needs to have a consent form. So be sure that that consent form is on file. Now, this is information that I got from the PAHO website. This was done, a presentation done by Dr. Adrian Martinez. It shows 2014, 2019, and 2020. I guess 2014 to 2019, that's just the statistics that they had available to present this information with. So you're going to see that in 2019, there was a pretty good collection of units, and that dropped in 2020. Of course, this report was based on the presence of COVID and how it affected the availability and use of blood donations. So we know that because of COVID, there was a 30% reduction in blood use. But there was also a low positivity rate. Now, every single blood that is donated, they have to test it for different microorganisms, HIV being the most common one. So there was like a 0.28% occurrence of HIV. Other things that they check for are hepatitis B when it's at its infectious stage, hepatitis B when it's already long-term, hepatitis C, syphilis, Chagas, and cytomegalovirus. All right. So now that we move on, we're looking at replacement and voluntary or unpaid donations. Now, replacements are the ones like, I have a family member that's sick, please donate some blood for her, him, and I give you that name, and you are going to donate blood in that name. That's considered a replacement. Now, if I feel like just up and donate some blood, that is a voluntary donation. So if you look at it, replacements are always higher than voluntary donations. But when you're looking at from 2019 to 2020, your replacements were lower, as well as that voluntary donation being just about half. All right. So we're expecting to see things like this because we had that lockdown period in 2020 as well. Now, looking at the units of blood collected and processed, you have 48% of the blood that was collected was made as whole blood, and then 25% as fresh frozen plasma, 25% as platelets, then you have some as stored plasma and cryo. Well, there was none in cryo. So now this is how we use the blood. Before, we were looking at how that blood was drawn and prepared. So now this is how we're actually looking at using it. Notice cryo is still at 0. We did not prepare any cryo and we did not use any cryo. So whole blood replaces volume. So that's one of our most popular things to do. Packed red cells increases oxygen carrying capacity. So your patient that has the sickle cell anemia, they would probably need packed red cells. So you also have fresh frozen plasma, which expands blood volume and provides clotting factor. So that patient who has lost a lot of blood in surgery, they may use fresh frozen plasma. That patient who has lost a lot of blood or has some blood deficiency by illness, they may be using fresh frozen plasma. That is considered plasma that is drawn and used within the first 8 hours of harvesting. Okay, so that doesn't need to be type and cross match at all. They just pull off the plasma and they can use the plasma. Your stored plasma is the one that, all right, they pull the plasma but they didn't use it within 8 hours of extracting it, so that's considered stored plasma. And then platelets, they mostly use platelets for bleeding disorders. And cryoprecipitate, that's the cryo. That is an anti-hemophilic factor. So people who have hemophilia would normally use cryo. So obviously we did not have issues like that. So maybe something like hemorrhagic dengue or something like that was not very prevalent. So we did not need to create any cryo. So this was taken from belmopanonline.com. We're looking at blood donations. Blood can be donated from a person 18 to 65 years old. 18, your age of consent. Over 65, you have struggles of your own. You need to deal with that. So it's best that you do not give blood after the age of 65. And we want that person to have at least 110 pounds. Now, when we're looking at a person with a weight of 110 pounds, we are trying to consider that removing a liter, a 500 cc's, sorry, a half liter of that person's blood may cause an imbalance in a person that did not have one to start with. So we leave those people with 110, they're very light people, we leave them alone. When you donate blood, you want to remove no more than 1 pint, which is 450 cc's, sorry. So we want to remove no more than 1 pint at every donation. After that, we're talking about creating an imbalance where there was no imbalance before. Blood can be donated every 3 months. Again, that goes with the life cycle of the red blood cells. So by the time 3 months have passed, you have already built back up those red blood cells. and your donation can be stored for up to 35 days. Now we're looking at that storage for 35 days because after that it's been shown that there have been an increase in reaction in blood reaction to the ones that have been stored for extended periods of time. So we try not to store blood for more than 35 days. So they make sure that they use a sterile technique when they're doing a blood donation, and you reinforce with your patient you cannot get HIV or any other disease while donating the blood. So we are using a sterile technique in order to draw this blood from you. We're not giving anything to you, therefore you're not likely to catch HIV or anything while you're donating blood. So all blood are tested for HIV, Chagas, Hep B, malaria, Hep C. That's not on this list, but Hep C is reported by the blood donor management, and syphilis is also tested. So now, who cannot donate blood? Any person who has had hepatitis on or after the age of 11. The microorganisms remain in the bloodstream. Same thing with malaria. Within the last 2 years, you could pass on that blood-borne disease if that titer isn't low enough. A person who in the moment of donation is ill, we do not want to worsen anybody's situation. We don't want to put people at a disadvantage. And then any person who permanently suffers from things like asthma, rheumatic fever, hypertension, goiter, heart disease, or stroke. We also look at those people who have seizures, diabetics, people with brucellosis, blood disease, cancers, or HIV or AIDS. All of these things are viruses or bacteria that can remain in the bloodstream, or diseases that use medication that can remain in the bloodstream and affect the people that are the recipients. So you don't want to have a person that's had a major surgery within the past year donate any kind of blood. Anybody who has been transfused, anybody who has been pregnant or had a miscarriage, abortion, or cesarean section, those people are still considered slightly delicate within 1 year of those events. And of course, we want to ensure, just for good measure, within 1 week of menstruation, we don't want to pull anybody's blood. And we also have a rule that it's more important in some places than in others. So they say that within 12 months of getting a tattoo, you should not be a donor. Now, some people don't want to accept your blood if you have a tattoo in the first place. I don't know who they're going to get as donors if that is the case, but the rule has been set fast internationally as 12 months after getting a tattoo, because at that point you have already established, if you have acquired any blood-borne disease. So now we look at the effects of COVID on donation. Now, we look specifically at this because this is relevant to what is currently happening. This is current issues. So if you have seasonal allergies, don't come give blood. It's like I tell you, when you come to class, if you have a cold, if you have a flu, if you have allergies, don't come to class, because we cannot differentiate by looking at you if that is COVID or allergies, COVID or a cold. So we do not want to have a person with the active virus in their blood donate blood. So for that matter, anybody who appears even slightly sick will not be a viable donor. So of course, those who have the infection or suspected of having the infection, or if you are a vaccine recipient. Now, the thing about this vaccine recipient, it is different depending on where you go, because some vaccines they're saying that you can donate with and some vaccines you cannot. I'm pretty sure that the regulations on this will change as we go along, because we are now at the point where we're mandating everyone to be vaccinated. And then there's also a thing of convalescent plasma. This is also one of the changes that has been it's come about as a result of COVID. Now, convalescent plasma refers to anyone who is recovered from the disease. So that plasma then has antibodies that are, well, they're proteins that are developed as a response to the body fighting off the infection. So we're saying that convalescent plasma from the patient who's already recovered from the disease may provide that antibody to the recipient. So especially for patients who are already COVID-19 positive and they're having complications that go along with it that require that transfusion, they're saying that convalescent plasma is one of the best options for them. So that concludes the rest of everything that we have to go through for the blood donors portion. I look forward to going through this information with you and answering questions as we go along. Hopefully, you guys have the opportunity to review this information and be able to perform very efficiently based on the information that is shared with you here today. Thank you very much for being with me.